This meeting is being recorded.
All right. Good morning, everybody, and good afternoon for those of you across the Atlantic. Welcome to Cardinal Health's latest roundtable on VT prophylaxis and treatment. My name is Manoj Sayal. I'm a general surgeon and intensive care physician from Oakville, Ontario, which is just outside of Toronto, Canada. I have the honor of moderating today's session, and we have a very fascinating agenda with a distinguished panel of speakers from around the world. A few guidelines, a few rules beforehand. Any questions, please direct towards the Q&A box at the bottom of your screen, and they will be dealt with towards the end of the seminar. I would like to start by introducing our panel of speakers this morning. First is Dr. Amy Campbell.
Hi, everyone. I'm Dr. Amy Campbell. I'm a PhD prepared nurse from the southern part of the United States. I manage VTE or thrombosis care throughout this region, and I'm just so thankful for the opportunity to be with this talented panel today.
Next, we have Dr. Vanina Barros. Okay, we may be having...
Sorry, I'll begin again. My name is Vanina Barros. I'm a gynecologist and obstetrics, and I'm working with VTE prevention for a long time, more than 10 years now. And I'm very happy to be here and to share this knowledge with you.
And where are you joining us from, Dr. Barros?
Sorry?
Where are you joining us from?
Brazil. I'm from Brazil, São Paulo.
Brilliant.
I'm here. Very happy to receive you here.
And now we're going to go across the pond and introduce Dr. Murto Folletto.
Hi, good afternoon and good morning, everybody. It depends on your meridian. And I am a bariatric surgeon. I'm based in Italy, northeastern part of Italy, close to Venice, in Padua University. And I'm doing my practice on obesity surgery. That is one of the field that represents one of the more risky situation in terms of VT risk.
Excellent. And last but definitely not least, we have Professor Michel Caron.
Hello, everyone. I'm Michele Caron. I'm an anesthesiologist and associate professor at the University of Padua in north of Italy, close to Venice. As an anesthesiologist, my daily work is to ensure a safe perioperative care of patients undergoing surgery. And in the context of general anesthesia, my field of interest is bariatric anesthesia. And as a professor, my daily mission is to provide knowledge, experience, all necessary tools to support the growth, the future anesthesiology, and possible to conduct research and to enhance in the patient care. I'm delighted to be here with you and to share my knowledge and experience about the topic. Thank you for having me.
Excellent. So as you can see, we have a very distinguished and a very broadly experienced group of speakers this morning, and they're going to be expounding their experience, their knowledge, and their wisdom as to how we can minimize risk of this particular complication in our surgical patients. We are going to be going through a few topics this morning. We're going to talk a little bit about risk factors for VTE and prevention. We're going to talk about guidelines or protocols in terms of how to manage this. And then we're going to end with some talks about education and then have a question and answer session. So let's start with risk factors. Surgery is a complex and physiologically stressful situation. The patient's hemostatic mechanisms are disrupted during and after the procedure. This results in an increase in many complications, including infection, cardiac events, electrolyte disturbances, and definitely thromboembolic events. This, on top of the pre-existing illnesses that our patients present with and conditions such as cancer, puts them at an even higher risk of VTE. Add a prolonged operation, a pelvic operation, and the risk increases that much more. Virchow described his original triad of risk factors for VTE in 1856, and today that triad holds just as true, modified by other risk factors that we deal with. I'm going to turn it over to Drs. Folletto and Professor Caron to discuss this further.
Okay, thank you very much. We are facing, I think, something that sometimes is not so evident also in clinical practice, and that we are facing something that is closely linked with the surgical practice every day, because all the risk factors that are, aligned in this slide are common for surgeon daily life. And as you can see, one of the most evident factor is obesity, that it's by itself a strong risk factor in terms of VTE, and also something that is promoting all the other risk factors. We should keep in mind that in Europe, the cost of VTE is roughly around 1 million euros. There is such a consistency, and also the call for premature death is around 500,000. That is really costly in terms of lives. And I think that the most evident in real life picture is that this is not something that is occurring right after surgery, but it's occurring mainly, as you can see, more than 90% after patient discharge and within at least 1 month from the index operation. That is to say, you must be aware of these threats, and you must be also make the patient aware of this, because only half of the patient can experience asymptomatic venous thromboembolism after surgery, and the proper management should be started right after the operation and not right after the discharging.
Professor Caron?
Well, this is an interesting introduction by Dr. Folletto. We have to consider that when patients are at increased risk and undergoing to surgery, we have to adopt any strategy to reduce venous thromboembolism events. And the most important is the use of coagulation, anticoagulation, and mechanical thromboprophylaxis. But in some patients, there is a risk, such as obese patients, that this problem became very bigger. And this is the reason for which we have discussed at the recent international meeting about the role of a new strategy involved in manage obese patients or high-risk patients in general. For example, there is data from clinical practice that there is a cumulative incident and VTE increase over the time after surgery. And often VTE occur after hospital discharge and often after cessation of thromboprophylaxis. And there is some case of VTE that occur even when an aggressive prophylaxis anticoagulation is employed. So we have to change the strategy and to use a multimodal approach to VTE prevention, and sometimes to extend thromboprophylaxis period, because a short period may be not sufficient. Multimodal thromboprophylaxis is a strategy that combines different strategies together to maximize VTE prevention compared a single approach, and is extensive adopted in general anesthesia. And this is important because we have to consider that two strategies may offer a better outcome at post-operative care of patients. This is suggested, for example, by American Society of Hematology 2019 guidelines, which strongly recommend combination of pharmacological and mechanical thromboprophylaxis that is associated with reduce by 66% of complication. And this is very important. But the multimodal approach is not only a combination of mechanical and chemical prophylaxis, maybe also a combination of different pharmacological strategies. For example, combining antiplatelet and anticoagulation, because are two important determinants for VTE. Empirical coagulation, hypercoagulability, and empirical aggregation, hyperactivities, both can increase the risk. So we can sometimes in high risk balancing risk benefit to combine anticoagulation, antiplatelet therapy that in general population patients show to reduce the risk, significantly the risk of VTE in post-operative period. And the last but not least is to use sometimes an extended prophylaxis by using, for example, aspirin, because aspirin show to reduce alone compared not to use aspirin the VTE events, and not only in a short period, in early period, for example, 1, 2, 3 weeks after surgery, but also at 1 month, 2 months after surgery, where the risk is not decreased, is not an item, is not absence. So it's important, for example, to consider in some patients to extend or to switch from anticoagulation to antiplatelet prophylaxis for long period that was that showed to be associated with reduction of VTE events. This is an important aspect that we have discussed at this international meeting, and this is a key message that I would to give to the audience, because the knowledge is important about this aspect.
Okay, thank you. Dr. Barros, anything to add to risk factor recognition and modification in your obstetrical population?
Oh, thank you for this question, Professor Manoj. Yes, some things are similar in the obstetric and gynecology population, especially in obstetrics, when we have in the last years, the patients are get pregnant in an ager year. So they are over 45 years, 10% of them in my city, São Paulo, in Brazil, University of São Paulo, we have a 10% of the patient ager than 40 years. And then we have similar problems. We have obesity. It is a national problem too. 60% of our population have obesity, and it's the same happens in the obstetric population. And also, they have the current of this, we have clinical problems. And also we had in the recent years, the association of cancer and pregnancy, especially breast cancer. And this patient can be treated and they receive chemotherapy. And this is also a risk for VTE and has been challenging for us. So these are new risk factors, and we have here in my city, São Paulo, VTE as the 50th cause of maternal death. And the same is happening in these developed countries. So these factors the other colleagues have pointed happens in the obstetric population. And the previous professor said that they use the ASH protocol. And the ASH protocol, American Society of Hematology, is not good for obstetric because it practically doesn't indicate pharmacoprophylaxis for anybody. And then we have adopted a protocol in Brazil based in Royal College and based also in CHEST. And this is a clinics hospital protocol. And then later I'll talk about that, okay?
All right, and Dr. Campbell, any thoughts from the other side, from your practice?
Yeah, I think one of the things is to consider the risk factors before when they're in the clinic or before the surgery, just meeting with them, talking with them, explaining what a blood clot is. For some reason, we often think blood clots are something that happen to older people, or if I'm 20 years old, that's not going to happen to me. That's not a problem for me. So one of the things I like to do is even before they have surgery, talk about what are their risk factors. And the risk factor that everyone is going to have is immobility. And like the panel has mentioned, as we are dealing with a more obese population, that population, because of their health factors, they're probably not up walking and exercising a lot anyway. And with movement being medicine and wanting to get people up and move, one of the big things I talk about before surgery even happens, if I have the opportunity, if it's a situation where they've had a trauma or they've had an accident and that's led to surgery, then I haven't had that opportunity. But when I go over the risk factors, I talk about you need to move. You need to get up. We want to prevent stasis with you. You're on this medication. This medication can lead to hypercoagulability. This can make you form blood clots in your legs that then can lead to one in the lungs, which is critical. And I try to explain it to them in very simple terms. And then we are going to use a multimodal approach. We're going to be using chemical prophylaxis, which is going to be a medication. And then we're also going to be probably doing something along SVDs, which are your compression devices on your legs to try to squeeze. I call them the squeezers, the huggers, or foot pumps to really try to promote that blood flow to prevent clots. So a big takeaway for me is it's hard. We have guidelines because everyone is dealing with different comorbidities, but starting those conversations early are so important.
Great point. And if we go back to the slide, the first slide that had the guidelines listed, sorry, the risk factors listed, they are, there's modifiable risk factors and there's non-modifiable risk factors. And I think recognizing the modifiable ones and minimizing the impact on the patient during their perioperative course is probably what everyone's saying is what we need to recognize and move on with. Well, that's a great segue to the next portion of our talk, and that's guidelines and protocols. As we all know, there's a million ways to skin a cat. Same thing holds true for surgery. There's a million ways to do everything. But best outcomes tend to be in patients who are protocolized. It mitigates risk, both surgical and medical legal. Protocols do exist. They're a little different on either side of the Atlantic, and the groups that put them out are sort of in agreement for the most part, but not quite 100%, which makes it nice to have a little bit of variability. Let's start with Dr. Campbell. What guidelines and protocols do you use at your institution?
We focus a lot in the United States, and where I am in the southern part are using the CHEST guidelines. The underpinning of this committee is to use evidence-based practice and research to help with any diseases of the chest, the reason it's CHEST guidelines. But I really found this helpful when we were dealing with COVID, and we know we were getting really big pulmonary embolisms, and how do you deal with that? And it does disease specific, because how you're going to treat your orthopedic patients versus how you're going to treat your bariatric patients is going to be different. And so I think looking at guidelines of how you want to treat your patients and making sure it's evidence-based is so important. And that's what Thrombosis Canada and the CHEST guidelines do, because people are going to come in with different things going on with them, and you're looking at different outcomes. And for example, what do you do for someone who is coming in that has cancer, has low platelets, and is actively bleeding? What do you do when you're faced with all these different things? Or you have a spinal surgery where you know they're going to have high blood loss. Do we prophylax them before? Do you prophylax them at 24 hours? And like it was mentioned at the very beginning, what we do in that first 48 hours is so important for their trajectory 3 weeks from now, 4 weeks from now, when we know they may be at home with their family, away from healthcare, and they get up and then they have a blood clot. And that's where we have that mortality or have a really bad outcome. And I open this discussion up to the panel that is familiar with these guidelines, or if they have anything else to add.
Great points. Yeah, and I agree. And being Canadian myself, the Thrombosis Canada guidelines work really well for us as well. Dr. Barros, you indicated earlier that there are not really good guidelines in the world of obstetrics and gynecology for this. What do you use then to determine your prophylaxis for your patients?
Well, in the last 10 years, we have adopted this protocol here that's called the clinics protocol. I'm going to share it with you. It has just been published this month and this year in June, and it's based on Royal College and in CHEST too. And we have scored this population in high risk factors, moderate risk factors, and low risk factors. And of course, it is always important, as Professor Amy has said, to see the risk of bleeding. So we have this indication for thromboprophylaxis, but many times it's not possible to do the pharmacologic prophylaxis because you have this problem of bleeding too. We have a population that, obstetric population that has a VTE risk, but also it's a bleeding population, isn't it? So I think I agree with Dr. Amy that we need to get a team that have to know how to manage this patient, and this is every certain time. But as we have adopted this, we have no more in-hospital maternal death till 3 months after discharge. And as everybody has said before, obstetric population, the risk persisted till 15 days. Some high-risk patients, for instance, patients who had already had an VTE previous to pregnancy, maybe the risk can persist after 3 months. So always in our obstetric population, we need to do the anticoagulation, the high-risk population, for 15 days. And I think we had a huge success during these years, because when we have adopted this protocol in our ward, we have reduced the VTE 87%, and we have had no maternal death from VTE. And I think it's important, this adoption of some protocol, and get used to it. And now in Brazil, you have this month, the Brazilian Society of Thrombosis and Hemostasis has approved a law together with a senator, and now we'll have a law that obligates all the hospitals to have a VTE protocol for every patient that is hospitalized. So this is going to be important for all the areas, including obstetrics. And this score, as I said, and we had no more maternal deaths, and a low indication for TPX that occurred in 15% of the patients. And as I has already said, the main risk factor are clinical factors. The patients at risk as maternal age, multiparity, obesity, severe infections, multiple pregnancy. We have 6% of multiple pregnancies in our service, and cancer was main risk factor for VTE. Because during a long time, we were discussing that C-section was a risk for VTE. And we know now that there are many risk factors, and doesn't depend on the way the patient is delivered. The risk factor exists independent of the delivery way the patient will have. Okay, then I think that's what I would like to say now.
All right, Dr. Folletto, you have a unique population that you deal with. What do you do in terms of protocols or guidelines for minimizing VTE risk in your population in Padova?
Yes, we developed also, as you know, and published a score that is called the Padua score, that is quite similar to the one that was shown by Dr. Barros. But I think that obese population and obese people who underwent weight loss surgery are quite different, because they are considered a very risk of population, but we extensively use the so-called ERAPS approach, that is to say, enhanced recovery after surgery. That is really impacting component in terms of reducing VTE risk. And the other key issue that is that in the post-operative course, we have to balance the risk of VTE against the risk of bleeding, because we are dealing with prompt and very early discharging. And I showed in the first slide that VTE occurs much more in the late, that is to say, late after the discharge, and this is a really issue that is sometimes has a very, very strong impact. And it should be keep in mind that the regular, that is to say, the normal protocols that are used for cancer patients do not, unfortunately, fit properly the obesity setting. That is to say, we are using a local guidelines that was developed according to the national guidelines. That is to say that we are discharging on the patient with at least low molecular weight heparin for 20 to 28th day. But in patient with higher risk, that is to say lower mobility due to their constitution, we are prone to extend the timing of VTE prophylaxis using, as Professor Caron said also, and the aspirin approach that is similarly, and it's appearing a good approach in the long run.
All right, Professor Caron, anything more to add to that, sir?
This is an interesting point, because Dr. Folletto suggested the new way to manage the high-risk patients, including obese patients. Because we have to consider that the risk is not limited to the early post-operative period. It's not limited to the first, second weeks after surgery. But it may be present also after 3, 4, 5, 2 months after surgery. So the physician, the colleagues, they maybe not consider to extend the chemoprophylaxis to the early post-operative period, for example, 20 days. But they should consider balancing the risk-benefit, the possibility to add aspirin, for example, after 20 days after the cessation of anticoagulation. Because the data and the evidence in literature suggest that the use, the administration, the aspirin after anticoagulation treatment, this is important, reduce the VTE by 32%. It's very important, 32%. And in the period in which the patient is receiving aspirin, the evidence suggests that there is a reduction of risk of major vascular events, myocardial infarction, stroke, cardiovascular death. So there are two benefits: prevention of VTE and the reduced risk of other major vascular events. And it may be extended, for example, for 1-2 months after surgery. This is an important aspect that we have to consider in clinical practice behind the guidelines that for which this aspect is not clear, but is discussed, is increasing the interest in this aspect.
All right. It's interesting because here in Canada, at least in my surgical population, you're right, ERAS has really helped minimize a lot of the post-operative risk we see. And I do practice 30 days or 28 to 30 days of thromboprophylaxis after any of my significant abdominal pelvic surgeries. Dr. Barros, has there been any thought of using dual therapy, i.e. mechanical and chemical, in the obstetrical population? And if so, is that something that's protocolized anywhere for people to be able to access?
Thank you for that question. Yes, we have noticed in the last years that although this high-risk population receive the chemical prophylaxis, in our country have only enoxaparin, and as you know, in the obstetric population, we have to use low molecular weight heparin in pregnancy, and that's a first choice. And then, but we have this special population that is obesity, multiple pregnancy, those patients that will have a surgery during pregnancy, for instance, fetal medicine surgeries, or as you said, abdominal surgeries, cholecystitis, and so on. And these patients should have a mechanical compression device during the surgery and after the surgery, as they can deambulate an early ambulation. And although they had this chemical prophylaxis, they have to receive this mechanical prophylaxis because they are really a very high risk population. So the mechanical prophylaxis is very important. And I have to thank you, Cardinal Health, because I have Luis and I have Luciana here in Brazil, and they do help us very much in our hospital with this mechanical prophylaxis, and it's been very effective.
Excellent. And Dr. Caron, question for you. You said aspirin seems to help after the chemical thromboprophylaxis is discontinued. How long are you continuing the aspirin for after, say, bariatric surgery or a bowel resection for cancer?
Mechanical prophylaxis, you intend imaging?
No, the aspirin. You said you've been adding aspirin. How long do you continue the aspirin for in this population?
The aspirin should be continued for at least 3 months after surgery. For at least 3 months. Sometimes some evidence suggests to continue the use aspirin after anticoagulation for 1 year after surgery, but is not so clear the evidence. But 3 months are clear because we have data that suggests that the incidence of VTE are low in post-operative period in bariatric surgery, after bariatric surgery, because there is a strong anticoagulation and this reduces the risk. But we have observed that, for example, after 3 months, we have still more than 3% of patients that may experience VTE. And this incidence is increasing over the time. While in general population, we observe a decrease of the incidence. So we have higher incident in early postoperative period after surgery, and then decrease over the time. In obese or in a surgery involving obese patient, the incidence increase over the time. So we have to counteract the effect of this increased risk by adding or extending anticoagulation, but better using antiplatelet therapy that has been shown to be very effective, and in some settings, such as orthopedic setting, recently has been shown to be an alternative strategy to low molecular weight heparin. So it's a very, very effective and associated with lower risk of bleeding as observed in using anticoagulation.
Excellent.
May I say something, Professor Manoj?
Go ahead.
Right. Well, I do like very much this idea of aspirin, but I do think we doesn't have protocols or studies realized with this field. As he said, we have some studies in orthopedics. I've seen the published studies in orthopedics, but I really think it's a good idea, and I think I could do that in my country too, here in my service. And the extended prophylaxis is much cheaper when you use aspirin, there's no doubt, and much more practical. But I do think that we need more studies about that. But I do like this idea because it's very simple, and those patients who have a doubt, well, they risk persist. For instance, in obesity, a patient who has a BMI of 40 will not be normal in 30 days after delivery. So this is a good patient to use aspirin after the 15 first days, for instance. That I think we need more studies about that, more trials about that.
I agree, and it looks like Dr. Campbell is nodding her head in agreement too. So
Yeah, I really like that you brought up aspirin, because what I have found is many of our patients cannot afford the anticoagulation once they go home. Either they do not have insurance, or they get a coupon that lets them have that anticoagulation for 30 days. So then at 31, 32, 33, that's when they're having the clots because they've ran out of medication and they can't afford it. So I love the idea, and I agree there needs to be more research with it, but aspirin is better than them not taking anything. And if you have a population that's not moving, they're already dealing with all these lifestyle things that are happening. And I think we have this around the world where we have food insecurity, financial insecurity, and they can't go out and just go get their Xarelto or whatever, Coumadin, heparin. They can't just go out and get it, but most of them can go get a bottle of aspirin. So I agree, that is definitely better to send them on aspirin and walking twice a day than them sitting and not taking anything. So I think that's an excellent point.
If I can add something too, is that we should consider the consistency of obesity rate in general population that is of course different among different countries, but it's quite consistently. And so this is not only a matter of weight loss surgery where the programs of lifestyle changes are more well established. We are dealing with an obese patient who has undergone surgery for cancer. Maybe it's less prone at home to be, encouraged to early mobilization because he's got different issues regarding his general health. And that's why it is really important to adopt a multimodal approach. That is to say, extensively use the IPC that was developed and sold by Cardinal Health. That is the pneumatic compression in bed that can be self-managed by the patient. This is something that we experience at home, and is something that is going to give patient also a well-being sensation during the hospital stay, because he can manage just to wrap and unwrap the pneumatic cuff. And also the idea to extend the effect of anti-prophylaxis right after the so-called regular period, that is to say roughly around 1 month after surgery, between 20 and 28 days. So we should keep in mind, because this is something that is affecting a consistent part of our population all over the world. And otherwise we are going to experience soaring up numbers of VTE that are most often misleading and misunderstood.
Good point. And you know what? Our discussion typifies that old saying, right? An ounce of prevention is worth a pound of cure. like you said, if it costs €1 million in your neck of the woods to treat a blood clot, we're looking at similar numbers here, and a $2 bottle of aspirin, if it can prevent that, would be the best thing. Well, you know what, that leads us into our final topic for this morning, and that's education. And as we've discussed, it's important that patients and families be aware of VTE, risk factors for VTE, signs and symptoms. And this education, as everyone's alluded to, begins preoperatively, continues while in the hospital, and has to extend to the postoperative time for the duration that we think is important. Dr. Campbell, what do you guys do at your institution to help facilitate this?
We try to be creative and meet our population. We deal with from 18-year-olds to, people in their late 90s, just like you do. One of the things we did was we did a mini grant project where we bought the supplies. And, we're dealing with a workforce that is exhausted and they're tired after COVID. And on my role of coming behind and trying to audit and tell them ways to do things, there's a connection with doing things that are fun and doing art projects. And this is one that we did that dealt with, and it came from Socks for Clots. This was another organization. You can look at the QR code, and I copied that best practice, wrote a grant. I gave the project in a box to each one of the wards or units, and what they received was socks, stickers, markers, and they were able to create socks on VTE prevention. And they also got the family members involved, and I encouraged them on their private Facebook pages to also promote this and promote how do we prevent VTEs. Let's start talking about blood clots. This is not just something that happens to one population. This is something that can happen to any of us. And I have a lot of Supermans, which I've round on a lot of young men, young women, so I guess it's super women, who think, oh, I don't need to wear the compression devices. I don't need to take the Lovenox. I'm fine. I'm healthy. But even Superman has kryptonite. So doing the Socks for Clots is a great way to have those conversations about using the compression devices, or huggers as I call them, and taking that chemical prophylaxis and what it does for the clotting cascade and how it really is a lifesaver. So something as simple as decorating a clot could save someone's life. So this is just one of the creative things we've done. Recently, we've started the squeeze bowl, which we're actually auditing on each one of the units, how well they are wearing their compression devices. And we are using the American football field and moving the unit on the football field to help them to score. And this is just fun, but it's also us auditing and validating and verifying that we are doing the best practices for the patient. Because I think everyone has said this, we're making this connection. We educate, we identify there's a risk, then we apply these protocols and we write these orders for things that we know are best practices and highly reliable. Now we need to carry them out. So I think closing the loop on that is making sure the families and patients are educated. So all these great things that we're ordering, they're actually doing.
Excellent. Dr. Falletto, do you guys do the same sort of thing in Italy?
We do not have such an established, movement, that is to say, socks and socks and against DVT. But our experience was that education means empowerment of the patient. That is to say, and if you are used to discharge a patient in group as we do, they can share these kind of concepts, and they can understand better that the awareness of this VT issue can be consistent. That is to say, they need to be reduce immobility, enhance, of course, deambulation, and also herniambulation is a key concept. But networking and empowering the patient, I think, is a key issue. Also for the physician themselves, because sometimes this is a neglected part because we respect protocols, but because of insurance issues, but sometimes we don't trust them so much because we are from my point of view, as a surgeon, I'm scared also regarding bleeding at home. That is to say, it can be a disaster whenever coming from home. But we should increase our awareness. We should increase the patient empowerment and involving, of course, relatives. And this is our way of doing. That is to say, we are grouping patient at discharge because we used to do 6 to 7 cases per day. And at the day of discharge, we are making a meeting with the nurse and the dietitian, just to say them advice regarding alert signs during the home stay, and also during and how to use at the best what the tools that were given in the hospital. I don't think there is I saw in the Q&A, there was somebody who was asking regarding mechanical prophylaxis, that is to say intermittent pneumatic compression at home. There's no need in my experience for the patient that we are used to deal with, but because it's it's a matter of well-being during the hospital stay and in the early hospital stay period, but they need to be aware that this can be really a life-threatening situation, and also this should encourage them to pursue all the advices that were given at discharge, because unfortunately we are dealing with a very maybe short stay in the hospital. We are almost doing all the cases in an ambulatory setting, and that's much more important nowadays than they were in the past.
All right, and maybe give them some nice Italian merino wool socks then, if they're not going to give them the socks that Amy has. Dr. Barros, anything more to add?
Yes, I would like to say that we need to really need to work nowadays on medical education, because as Dr. Mileto said, many doctors just ignore the risk of DTE. They just simply don't do the patient scoring of the risk, and they doesn't do. There are hospitals in my country that just don't ignore the risk. I had obstetric procedure, surgical patient, and patients like orthopedics and obesity. They have such a high risk that they were obliged to use a protocol. But we here and I struggle to get medical education, and we're working with that. We have a Brazilian Society of Thrombose and Hemostasis, and nowadays I'm the president of Association of Obstetric and Gynecology, a federal association. We do publish material for the medicals, orientation and classes and videos, and trying to engage this medical population to know the risk and show that this really happens with their patients. And many times we are called to have a class or have a speaker to some classes when a patient has died of thrombosis, and they say, wow, this really happens, doesn't it, and die. And so we really need today, nowadays, to work with medical education too. And the patient education, of course, it's obvious, it's very necessary, and the patient needs to know the risk. That's what we are working at.
And their families, absolutely.
Yeah, and the family.
All right. Well, that was a great session, guys. We covered a lot of material. Takeaway, we need to recognize risk factors. We need to modify them if they're modifiable. I think we need to treat the risk for longer than we have traditionally. And I think we need to make sure that our patients, their families, and more importantly, all of us are educated on the risk, as well as the signs, the symptoms, and the treatment for this particularly significant complication of what we do to people. So there's a number of questions from the audience. I'm just going to direct it out to the group in general. Question number one. I guess this will go to the group in general. What thromboprophylaxis do you recommend for obese patients when they're going home? Dr. Filetta already answered the question about mechanical prophylaxis. We don't think that's needed at home. what thromboprophylaxis would you guys recommend?
Our protocol is in hospital 4,000 enoxaparin and at home 6,000 enoxaparin. This is the guidelines that we developed here according to the Padova risk assessment protocol. For
Dr.
of
Campbell?
course.
Nice man. Well,
That,
in obese, sorry.
No, I suggested to add other important aspect about prophylaxis. We have a protocol that it's correct, but we are speaking to the audience, and the mobilization is a strong recommend. I encourage mobilization, as I suggested before, at least 2 times a day mobilization. And if not, mechanical prophylaxis is possible because intermittent pneumatic leg compression is not available at home. I suggest also to use graduated compression stockings for as much as possible, because it's another strategy that may be suggested to reduce the risk, and then to follow the recommendation. But most important, mobilization. And two other important aspect is that mechanical prophylaxis is very important. We have talk about chemical prophylaxis, but mechanical is the very important strategy, because it is the strategy similar of our body to counteract the blood clot formation when situation are at high risk. For example, immobilization, reduced mobility, and other risk factors that has been described at the beginning of this very important section. So mobilization and mechanical prophylaxis added to chemical prophylaxis.
Okay. This, again, just a quick answer from the group. You mentioned that asking the patient to find out what the risk factors are. We are all pressed for time. Who should be asking these questions? The nurse, the surgeon, or the anesthetist?
I think
Dr. Campbell?
everyone. Sorry,
Okay.
I think everyone should be asking those questions. I appreciate that we are pressed for time. There are things that can be built in the electronic medical record. You could have a predictive analytic with like a Caprini score that could already score them. So when you went to the chart, you already knew they were high risk. That could be built in the background. It's only as good as our history, so we'll still have to do the history. But sometimes when they're waiting, it could be one of the forms they fill out. But I think if you look at your time, it would only take 30 to 40 seconds to screen them for VT and let the nurse do it. And I know the nurse already has a lot on them, but I think we should all be asking those questions. I agree. I don't think we prophylax enough and we ask the right questions.
Okay.
Can I say one thing? I think that when we talk about obesity, we must distinguish those patients with a BMI greater than 40 and those with a BMI less than that. Because in obstetric population, the BMI greater than 40, we think they need some kind of prophylaxis, and maybe aspirin or maybe enoxaparin, when at least for 40 days, okay? When the risk of VT for the patient will be lower.
All right. And Dr. Barrow, somebody has asked, in some countries, they perform multiple C-sections as a normal delivery method. Is there a role for mechanical thromboprophylaxis in these patients?
You see, C-section by itself, it's not a risky situation. It all depends on the other risk, and all depends on the type of C-section. The patients who are in C-section and who needs a mechanical prophylaxis are multiple pregnancy, twin pregnancy, those with obesity, and for patients who will have a long-lasting surgery, for instance, complication, atony, this patient need a special device to his surgery.
And for the group, when we say to use guidelines or protocols, is it better to assess the patient as an individual for more personalized treatment or in a grouped way?
Oh, always individual.
I do agree.
The guidelines are great as a framework, and then we individualize it to the individual patient.
Yeah. I always do that.
Okay. Well, with that, that's the end of our questions. I want to thank everybody for coming out today. I want to thank our panel. You guys have been awesome, given some great advice, some great suggestions, and some great strategies on how we can minimize the risk of this particular complication in our surgical group. That brings to an end our session this morning. I want to thank everybody for participating. And as it says on the slide in front of you, just take a few minutes to take the survey and provide feedback on how the session was and thoughts and of what you thought, how things went. These webinars are all available on demand. This is the third in a series of them that have been done. They're available on demand as long as you sign up for the Cardinal Health website. And again, I want to thank everybody for coming out today, this morning, this afternoon, and participating in this particularly important discussion. Thanks, everyone.
Thank you very much.
Thank you very much. It's a pleasure.
Bye-bye.